Good evening, everyone. Thank you for joining us tonight. This is Amy Lamb, your AOTA President. Happy to have all of you with us this evening. We are going to be talking about volume to value and how we can maximize the opportunity for occupational therapy. We have two members of our quality team with us this evening from AOTA staff that are joining me tonight. Jeremy Furniss, who is the Director of Quality, and Sharmila Sandhu, who is the Director of Regulatory Affairs. They're both on the line this evening as well, and so you're going to be hearing from them in just a few minutes. A couple of things that I just want to remind everybody: if this is your first Member Appreciation Plus webinar, welcome. We're happy to have you here. Just so that you know, this platform does require you to stay on the line until the end. You'll see a box that pops up that says the webinar is now over, and it's important for you to stay on until the end and see that box so that you can get the CE credit for attending tonight's webinar. Also, just wanted to take a quick minute to highlight that next week is the start of November, and in the spirit of showing our gratefulness, AOTA does Member Appreciation Week, and so all next week you will have the opportunity to plug in to 2 sessions a day, Monday through Friday. One is from 12 to 1 Eastern, and the other is from 3 to 4 Eastern time. You can go to aota.org to get more information on those webinars, and we hope that you will join us there. And also have the opportunity to be able to earn 10 free CEs if you're able to join us for all of those. So we just wanted to make sure that you know that you have lots of opportunities to be able to plug into some of the things that are happening at AOTA. In addition to the quality team that we have on this evening, and Jen Bogenreith is not able to be with us tonight, but she is a member of the quality team as well at AOTA. We also have a quality advisory group. And this is a group of AOTA members who works together closely with the quality team and works on helping to talk about what's happening out in the landscape and how we can position occupational therapy for success. So our agenda this evening is to really talk about a couple of things. We're going to talk about shifting payment systems. We're going to talk about what OT services and incentives look like today. That's the volume world that many of us have been living in for a very long time. We're going to give you a countdown to new value-based programs, and then we're going to focus in on what OT services and incentives look like in tomorrow, which is the world of value. And we're also going to talk about what occupational therapy's response is in terms of how the quality program and how AOTA's quality team has really positioned us to be able to step forward into this new payment system as we move forward. So let's talk a little bit about those shifting payment systems. As many of you know, or you may have been reading, we are shifting to value-based care. So we're going to be finding that our payments are not going to be based off of the volume of care. It's not fee for service for the minutes of therapy that you're putting up, but we're moving into this value-based payment system. It's about performance, it's about what kind of outcomes you're producing, and it's all about quality of care. And this really has the opportunity to position occupational therapy for great success as we move into this new payment system. There's certainly some challenges out there as well, and we're going to discuss those as well as how to be able to navigate within that realm. So the patient-driven payment model is something that we did a webinar in August of 2018, and this is something that's coming out in the Skilled Nursing Facility Part A payment. It'll go into effect in October of 2019. We'll be talking about it a little bit more later in the webinar, but what you'll find in this new payment model is that we're focusing on patient characteristics. There's a focus on the functional level. And one of the key differences that we're going to be noticing in practice is that therapy intensity and the minutes do not impact payment. And this is different for occupational therapy, for physical therapy, for all of the different parts of rehab as we think about moving in this new payment model, and then also the facilities and organizations that we're working in. And so we have some tools and strategies to be able to help you navigate that. One of the things that I think is important, and I did this in some previous presentations that I've done over the last month, is to really be able to study our past to be able to develop that strategy for the future. So some of you on the call may remember the Balanced Budget Act in the 90s. I often refer to myself as a product of the Balanced Budget Act. It was the Balanced Budget Act went into effect when I was in practice, and that's really what taught me about the link between policy and practice. And it taught me about the link between policy and practice in a very harsh way. I was one of 100 occupational therapy professionals who lost my job in a weekend because of the payment change. And just to put that into context for you, there were only about 700 licensees in the state of Nebraska at that time. And so that was a real eye-opening experience for me as a practitioner to be able to say, where did this come from and how can we maneuver with that? So it's important for us to think about how can we learn from those past experiences that we had during the 90s to have a strategy as we're moving forward into this next payment shift of going from volume to value. So a couple of slides, and you know, these are things that you might want to you know, peruse after the webinar is over a little bit more in depth. But these are some slides that just show the OT primary work setting. And it shows us between 1997 and 2014. And so if you really study these, you can see what happened after the Balanced Budget Act happened, and you'll see in 97, many practitioners were in long-term care SNFs and in hospitals. You see that hospitals stayed pretty constant throughout. You'll see that we saw that big drop in 2000 with long-term care and SNFs, and then you can see kind of too where the workforce shifted. So the OT workforce really shifted over to schools, and you'll see that freestanding outpatients went out, some went into academia, mental health went up a little bit. So it's interesting to kind of study some of the work trends. For the OTA setting, we had the same sort of things. We saw the drop in long-term care SNFs, and we saw our occupational therapy assistant practitioners, again, really moving over into, we saw an increase in academia, we saw increases in outpatient, we saw increases in schools. So it kind of shows us where people went after the changes in the 90s. This slide, there's a lot of numbers on it, and you know, some of you may be looking at it and thinking, I am not a numbers person. But one of the things that I think is interesting, if you look at the highlighted lines there, it just shows you how the workforce has grown. And so in 1997, in the skilled nursing facilities, for example, we had just over 14,000 OTs working in skilled nursing facilities. In 2000, we had just under 10,000. And then just to put that into context with where we were last year, we have 27,000 working in skilled nursing facilities. So it kind of shows you those numbers, which I think has it's a nice visual for us to think about as how we move forward. Then we have the workforce growth summary as well for the occupational therapy assistant. If we kind of look at that same kind of area there with long-term care and SNFs, in 95 we had just under 9,000. That number in 2000, it was just under 10. So there was, you know, a bit of a difference, and had probably already started to sweep back up a bit by 2000. But you'll see here in 2017, we had just over 32,000. So thinking about the number of individuals that we have in these different parts of our workforce and how many are in the skilled nursing facility community, and thinking about the new payment change that's coming there, this is a conversation that's important for us to be having as a profession so that we can prepare and make sure that we're positioning ourselves well for when this new payment model comes into play. This slide just shows us a little bit over salaries. I get the question a lot in terms of as payments shift, what happens to salaries. You know, it really shows you that there was a slight drop after the 90s. With the change in payment system, but that has incrementally built its way back up. OTAs stayed pretty even between 97 and 2000 numbers there. You'll see the OT had a bit of a drop overall. And these are just general numbers in terms of data. They're not from any specific setting, but it kind of gives you an idea of you know, how salaries have grown as well over the time. So we just wanted to lay a little bit of that context, and with that, I'm going to turn it over to Jeremy to dive in a little bit deeper here to the volume in looking at the OT services and incentives today.
Excellent. Thank you so much. So let's start looking at the way that OT services are reimbursed at the organizational level for right now. So let's look at Medicare, OT services and Medicare payment today. If we start with that, then there's some amount of OT services at your organization or in the facilities. And this is represented by staff, the number of OT practitioners we have, hours, including like the number of PRN hours that are available on the weekends and holidays, and also productivity. And so right now, healthcare organizations are paying the salaries and benefits and other costs associated with providing these OT services. So that's the representation there. And then after those OT services are provided, the organization achieves reimbursement in the form of dollars. And so OT services are provided, organization achieves reimbursement. And this purple block here is the excess reimbursement that the organization achieves. So after paying for all of the cost of OT services, there's money left over, and that organization can use that leftover money for things like improving facilities, paying for non-clinical staff, buying equipment, and other client-centered or not so client-centered factors. So what happens right now is if we increase our OT services, and that could be hiring new staff, it could also be adding PRN hours or providing overtime hours for staff, and it can definitely be increasing the productivity requirements on OT. So when we increase those services like that, the organization also sees an increase in reimbursement. So we have excess marginal revenue left over that can be used for all of the different areas that a healthcare organization might want to use funds for. It also increases audit activity, and some of that audit activity will have negative findings, and those negative findings kind of cut into that extra revenue. So you see the revenue go down a little bit. So this explains the way that Medicare pays for a lot of OT services in a lot of settings today. And the incentives that it provides are, one, to hire more OT practitioners. We want to increase the number of OTs. You can see that from Dr. Lamb's numbers, where over the last decade, we've seen the number of OTs in many settings increase pretty substantially. It also provides the incentive to maximize productivity. So you want to be able to get the most billable units or the most minutes out of all of the OT practitioners that you have. And it puts a focus on defensive documentation, and that's to minimize that negative audit finding so that more of that marginal revenue is left over. So this is kind of the general picture for OT today in a reimbursement landscape. And it's not just for OT, but it's for most providers who bill units and directly bill to Medicare. And so Medicare is catching on and saying, hey, we need to make some changes. We want to see incentives shift from providing more care to providing better care. So this is an effort to change the incentives for health systems, even though some of the rules may seem a little out of left field. It really is aimed at the incentives. So tonight we're going to count down changes in 4 different practice areas. These are just the highlights. So we're providing a really brief overview of 4 different practice areas that really talk about what the future for OT is going to look like and how it's going to look different. So make sure to check out links for more information on AOTA.org. You'll be able to download the slides in the resources tab of the webinar, and we've provided them in PowerPoint so that you can use them and review them at your leisure. And also keep an eye out for new training modules. The quality team and advisors are working on training modules right now that are really going to dive in a lot more deeply into each of these practice areas. So keep an eye out for that. So we're going to start by looking at Medicare Part A and the skilled therapy provided in post-acute care for the most part. So Medicare Part A has 2 different quality programs that they use, and there are different levers to try to encourage value-based care in post-acute care. And we thought it would be helpful just to kind of talk through these just briefly because they seem to be competing a little bit, and it's very easy to get them confused. So the first Medicare Part A quality program is called Value-Based Purchasing, or VBP. And in VBP, there's quality measures that Medicare is calculating for each facility. And based on the performance on those quality measures, payment actually changes. So we've made this green throughout the presentation, kind of think green money. So payment actually changes on VBP. If you do really well on these quality measures compared to your peer organizations, the Medicare will literally pay more money for services because you're providing really high value services. If your organization does poorly on these measures, then Medicare will actually pay less. And so they take the money from the facilities that they pay less, and they give it to the facilities that they're paying more. So you actually kind of compete against your peer organizations in the areas. The other program is called the Quality Reporting Program, or QRP. This is a bit of a different lever. The idea behind this is to publicly report quality measures so that consumers and beneficiaries understand if your facility is providing really high value care or low value care, with the idea that if we provide better information to consumers, consumers will make more intelligent choices and choose high value facilities so that those facilities actually have an increased number of beneficiaries who use their services and are able to increase revenue in that way. And so this is going to be read throughout the presentation, and I think about it as quality reporting program is so that consumers stop and think about which venue they seek care in. And although we're taking the Medicare approach, Medicare really does set the stage for many of the private organizations and private payers and commercial insurers that are out there. So although we're looking at Medicare specifically, a lot of these same concepts either apply to other payers currently or are likely to apply to other payers in the future. So as Medicare goes, often goes the country. And since we're talking about post-acute care, we've got to touch base on the IMPACT Act just briefly. There's some information here on the slide. You can click on the link and read more about it. But the one thing that I'm going to focus on tonight is the IMPACT Act required that Medicare create some standardized data elements so that they're collecting similar data across post-acute care settings. And then it also requires that they create some standardized quality measures across those post-acute care settings as well. So there's a lot of different areas that apply to OT. One great example, and it's just one example, is Section GG. And that Section GG is showing up in each of the post-acute care settings. It has two parts to it. One is self-care and one is mobility, both of which apply to OT, but for tonight, we'll just take a look at self-care. There's some pretty great resources at aota.org/care that provides more details about the self-care and mobility items. There's also a link to a really great training that CMS has created for Section GG, and I would highly encourage any practitioner in post-acute care to go visit aota.org/care and review that CMS training. They've tailored it for each post-acute care setting. So you get to pick from the beginning if you're in SNF or long-term acute care or what setting you're in, and then it tailors the training specifically for that setting. And they even use OT as examples throughout. So I'd highly encourage everyone to review. You can see the 7 items for self-care that are in Section GG right there. Each of those 7 items are rated from 1 as dependent all the way up to 6 as independent. And that CMS training will help make sure that the ratings for each of these items are consistent across providers. We provided a downloadable resource. So once you've taken that CMS training, you can download the self-care and mobility items tool that AOTA put together. It's got each of the items that shows up. It's got the definition of those items. It's got how to rate them. And it's a really helpful tool to have on your clipboard or by your tablet or computer, just to remind yourself about what is actually included in Section GG for toilet hygiene, because it may be a bit different than the other items that have looked at toilet hygiene from CMS in the past. On the back of the first page, we also have a really colorful scoring algorithm. So once you've completed your training, this is really helpful just to kind of clue in to some of the specific elements that should be asked when determining which of the 6 ratings each of the items should have. So 1 from dependent to 6 to independent. So Section GG is another really important element that is changing and is growing across post-acute care. So with that, let's start our countdown. So we're going to start with number 4. We're going to count down backwards from the amount of time that we have to prepare for these major changes. So the first set of changes is really going to hit and be complete January 1st of 2020. So we have a little over a year to prepare for this one. And this is in home health. And so Section GG that we just finished discussing, home health is getting Section GG, the full complement. So it will be in the OASIS, and it will be something that CMS is collecting and that OT can really be a leader in. The QRP, or Quality Reporting Program, that's that public reporting of measures, is included in home health. They actually have self-care measures. They have some mobility measures as well. And those measures are based on legacy data elements, so data elements that have been collected in the OASIS for quite some time. They also have a value-based purchasing program that's just a demonstration right now. So in that demonstration, there's 9 states that are participating in value-based purchasing. So if you provide home health in one of these 9 states, then your agency must compete against other agencies in VBP. And if you're providing home health in outside of these 9 states, then your agency cannot compete in VBP. We are expecting them to expand the value-based purchasing program, but it's not being expanded for this next year. So the first payment adjustment that home health agencies are seeing based on value-based purchasing is January 1st of 2018. So January 1st of this year, all of the services billed from that point on are being adjusted based on VBP. So the lowest performing agencies are seeing a reduction in payment, and the highest performing agencies are seeing a bump or a boost or bonus in payment. So if you provide home health services in these 9 states, then you may have been hearing about quality measures that relate to payment in home health. And then also as of January 1st, 2020, therapy time is being taken out of the payment calculation altogether. So as it stands right now, there are thresholds, and once you reach a certain threshold of therapy visits, then your agency can get a bump in payment, and that is going away completely. So that OT visits, along with any other therapy provider, will no longer contribute to payment as of January 1st. And so we've got to start thinking about what is OT doing other than contributing to payment directly. Number 3, October 1st of 2019, is inpatient rehab facilities. And there are some pretty big changes in IRF. The biggest one is being that the functional independence measure, or FIN, is being completely replaced by Section GG. So that Section GG resource that we talked about earlier is becoming even more important. The functional independence measure still can be a great tool for OTs to use, but it will no longer be collected by Medicare in their IRF assessment. And it's going away completely, and GG is replacing it. The data elements in GG, those self-care and mobility items, are used both for quality measures and they're used for payment. So not only is the FIN being replaced, but it's being replaced and that data is being used immediately. The quality reporting program is present in IRF. They do have self-care and mobility measures both, in addition to others. And all of those measures in that quality reporting program, or QRP, are based on Section GG. There is no value-based purchasing program in IRF yet, but we would expect it to be considered in the future. And therapy time really does not impact payment in IRF. There is a threshold of therapy time that qualifies someone for IRF, but it does not actually replace, it does not actually change payment, and that will maintain and be consistent. So number 2 is October 1st, 2019 as well. So a little less than a year to prepare, but this one is a much bigger one, and that is skilled nursing facilities. So in skilled nursing, you're seeing Section GG is being added. Starting this year, you'll see more items in Section GG than were present last year. and they are used for quality measures, and the data from GG is used for payment. So we're seeing section GG becoming very, very important across post-acute care. The QRP, or Quality Reporting Program, is present, and it does include self-care and mobility measures, both based on GG. And the value-based purchasing is present in SNF, and this is pretty new for SNF. In fact, the first payment adjustment is October 1st of 2018. So if you work in a skilled nursing facility, services as of the 1st of this month are going to be adjusted. So if you perform really well on VBP, then your SNF may be getting a bonus payment. And if your SNF was not aware or happened to perform poorly on those measures, then there will actually be a decrease in payment starting as of October 1st of this year. And therapy time, OT minutes will no longer contribute to payment as of October 1st of 2019. So again, about a year away. It's not just OT, it's all therapy minutes. But in skilled nursing right now, therapy minutes are a major driver of payment, and they're moving from a major driver to no consideration at all. So it will not change the reimbursement rate if a person receives 0 minutes of OT, or if they receive 2.5 hours of OT a day. The facility will be paid exactly the same way. So these are some major changes that we're seeing across the post-acute care. And before we get to number 1, I am going to pass off the conversation over to Sharmila Sandhu, who will fill us in on a few more details.
Thank you, Jeremy. I am interrupting your countdown at this moment just to talk from the policy advocacy perspective before we get to number 1, to give you a little bit more information about the PDPM, or the patient-driven payment model. Both Amy and Jeremy touched upon this, and we just wanted to take a brief, deeper dive into some of what this means, because it is such a big change for so many of our members. The patient-driven payment model is essentially changing the PPS, or prospective payment system, from what was a system of resource utilization groups, or what you might have heard of as RUGs, payment based on therapy RUGs, to a new framework that is really paying based on what CMS calls patient characteristics. And in doing so, CMS, or Centers for Medicare and Medicaid Services, have created these 6 components for payment under the new SNF framework. OT, PT, speech-language pathology services, nursing, non-therapy ancillary, and non-case mix services all contribute to the skilled nursing facility daily rate. One of the things that we wanted to point out is the PDPM. The new final rule was published in August this summer, 2018, and as Jeremy said, it won't be effective until October 2019, giving about a little bit over a year for skilled nursing facilities to sort of comply and adjust to the changes. The other thing I wanted to make sure I pointed out is that AOTA has done significant advocacy around PDPM for almost 3 years now. The work started with a technical expert panel on which we had a member participate, and we were able to advocate for the occupational therapy component to be separated from the physical therapy component. Initially, they were bundled together, and that was a huge success for us. In addition, I'm going to move on to this one. I wanted to kind of talk about what this meant for OT, and also some additional advocacy that we did in terms of successes. In addition to separating OT as a separate case mix, we fought very hard, along with the other therapy organizations, to identify a way, now that therapy minutes no longer count toward the payment rate for skilled nursing facilities. We fought very hard for a method to track therapy minutes so that we could ensure that medically necessary therapy would in fact continue to be provided to patients who needed occupational therapy as well as physical and speech therapy. And that was finalized to be the case in the final rule. There will be a section in the minimum data set for skilled nursing facilities that we believe will be titled Section O, on the discharge MDS assessment, where the the therapy minutes will be captured by discipline. So CMS will have a mechanism by which they can track what therapy and how much therapy each patient gets. And for us, that is a really important check and balance on the system that we're very concerned about, and we will be following that very closely. In addition, we advocated very strongly for a limit on group and concurrent therapy to ensure that individual therapy is provided as needed, and so that limit was put at 25%. There continues to be ongoing challenges with PDPM, however, one of which is that the area of cognition and comorbidities are not included in the OT and PT components, and so payments, in other words, do not vary based on interventions that relate and conditions that relate to cognition and multiple comorbidities, and that's something we at AOTA will continue to advocate to make sure are included in the future. And also the area of swallowing disorders and dysphagia was not recognized as a factor that contributes to the payment amount for occupational therapy, and we'll continue to advocate that that be included in the future. But we're very pleased that we can be able to track those minutes and ensure that medically necessary therapy is provided as needed. So these reimbursements, and let me step back to say that in August of 2018, just a couple of months ago, Jennifer Bogenreef, one of our members, Natalie Leland, and Amy Lamb, our president, did do a member appreciation plus on the PDPM and took a much deeper dive on the various components and how the system works. And so I encourage you to go up on our website and look for that member appreciation plus and listen to it. AOTA also created template letters for members to complete and submit to CMS as part of the larger federal notice and comment process, and many, many members did. So we really thank you for that and your continued work on these issues. So as Jeremy was saying, these changes really change the reimbursement incentives and levers to promote more efficient care at lower cost and really look at what is the quality that occupational therapy brings to the table. The more OT contributed to higher reimbursement for the facility and organization was the case in RUGs. RUGs are directly tied to therapy minutes, but in PDPM, more OT, we feel, can contribute to higher costs in the facility and organization. And so what we want to really demonstrate to you is that you have an opportunity here to show the quality of your services over the quantity. So really advocating for you. We have advocated for 3+ years. We will continue, and we'll be trying to push education out to you as much as we possibly can in continuing these efforts and in meeting with CMS face-to-face in their headquarter offices. Moving on very quickly, we wanted to just point out that in addition to value-based purchasing programs and quality reporting programs in all of the post-acute care settings, the acute hospital or the inpatient prospective payment system also has these programs. They each have a value-based purchasing quality reporting program, and these are some examples on this slide of the specific measures that might apply for each program, so that for those of you who are listening in the acute care settings understand that there actually is a very robust program in each of these areas and is something that AOTA is also very closely following. So stay tuned on that as well as we continue to comment on those issues. And then finally, AOTA next week, and we'll be highlighting several of these sessions. There is a Member Appreciation Week celebration coming up just next week. And related to policy advocacy, myself and Heather Parsons will be presenting on advocacy in action. We'll be talking about how you yourself as a member can become an advocate for AOTA. We will be walking through advocacy examples in legislation and legislative advocacy, as well as regulatory advocacy with CMS, to teach you how you can get involved with us. Also talking about getting involved with your federal representatives and getting involved with Hill Day, and how you can become involved with some of the technical expert panels that really does influence the policy that gets moved forward every day. And so with that, I'm just going to turn it right back to Jeremy to talk a little bit about OT services and value.
Thank you so much, Sharmila. So let's dig into value and OT services and incentives into the future. So yes, we're going to jump right back to our bar chart that we had at the beginning. So right now we have OT services on the left, and we have the organizational reimbursement on the right. And you see there that purple block where that would be the marginal revenue or the leftover extra revenue that the facility makes based on OT services. So based on these changes that we've talked about so far in our countdown, what happens when we increase OT services? Both staff could hire new OT practitioners or hours through PRN or overtime or other hours. We actually see a decrease in net revenue because increasing OT services in these settings no longer increases the organizational reimbursement. And so the facility ends up, or the organization ends up paying more for OT services than they are getting in revenue based on the new payment models. So that's the downside, but there is also a really great upside. We talked about value-based purchasing measures, so the VBP measures. If our facility is doing really great on the VBP measures, then our organizational reimbursement does go up. And so there is a way to increase that extra revenue and that extra cost if we see an increase in VBP measures. We also could see an increase in the number of consumers who are visiting our organization or our facility because our QRP measures have gone up. So the QRP measures are those publicly reported measures. And so if we identify as a really high quality facility, then we may see an increased consumers and beneficiaries. We may also see an increase in the VBP, both of which could increase the revenue. So this shifts the way that OT really needs to talk about our services. We need OT services to be able to identify where do we help improve QRP measures and where do we help increase VBP measures. So when OT is related to improvements in these quality measures, then we are really hitting on the new incentives for the healthcare system. So in this new system, the incentives here are maximize staff that have an impact on quality measures. So if you have staff that are really changing your quality measures, then you really want those staff and you want to maximize the utilization of those staff. The other side of that, though, is to minimize staff who have, to minimize staff that have a little or no impact on quality. So if staff aren't really associated with improved quality measures, then you want to minimize that cost. The focus here is on collaboration and documentation that identifies value. And then we also want to be able to identify gaps and improve care using quality measures. That's really what the measures are there for. So we want to identify the measures that we're not doing great on and then take steps to improve the care that we're providing and the outcomes that clients are achieving. So these are really the incentives that we think that OT should really be focused on. So we've talked about how important the QRP and VBP measures are. We wanted to give you guys a couple of examples. There's many, many more. And stay tuned for more information on all of these measures. But just to see a couple of examples, change in self-care based on section GG. So again, we're seeing GG pop up. The percent of residents experiencing one or more falls with major injury, that's super important for OT. So both of those are examples of QRP measures. We also have a skilled nursing facility 30-day readmission measure. Well, OTs really should be impacting the readmission that clients have in SNFs. And then we also see a new self-care measure that's popping up in home health that includes grooming, dressing, bathing, toilet hygiene, and eating, also part of the VBP program for home health, also something that is super critical and super important for OT. So yes, we are going to get to number one, and we have arrived. So number one major change is coming into effect January 1st of 2019, and that is just a few weeks away. And what's even a little more unnerving is the final set of rules for this program are not out yet. We're hoping to get the final set of rules in the next week or so, but we're waiting on Medicare to publish them and make them public. So we have some good ideas of what's going to happen, but keep in mind some things could change because the final rules aren't there. So this is called the Quality Payment Program, or QPP, and this impacts Medicare Part B outpatient charges. Now, so far, it does not impact facility-based therapists, so not like Part B in skilled nursing. although CMS specifically said in their rule that they're thinking about what that might look like, and they are interested in pursuing that Part B. But for this first year, it's basically your traditional outpatient settings that OTs work in. So in 2019, starting January 1st, the best performers in QPP can earn a 7% payment bonus. That payment would change in 2021. The worst performers can earn a 7% payment penalty. So in 2021, 2 OTs billing the exact same CPT codes could see a difference of up to 14% in Medicare payment, depending on how well they do in quality payment program. So that's pretty huge. Now, we do want to point out that there's a low volume threshold that helps determine eligibility. We're not going to get in that tonight just because of because of time, but stay tuned for more information on that as well. So QPP has 2 tracks. One track is called MIPS, the Merit-Based Incentive Payment System, and one track is Advanced APNs. So for tonight, we're taking Advanced APNs out of the equation. For the first year, it would be very, very hard, if not nearly impossible, for OTs to be in the Advanced APNs. We are keeping track of that and hope to include OTs in that track in the future. But for right now, let's just focus on MIPS. So MIPS scores OTs on 4 different categories. And these are categories that you're going to see have some correlations to some of the areas we were talking about earlier tonight. One of those is quality, and one is improvement activities. Now, the other 2 we don't think are going to apply to OT, so we're going to skip those over tonight, but they're cost and promoting interoperability. They may apply to OT in the future, but for year 1 in 2019, we don't think that they're going to apply. So quality, if you participated in PQRS in the past, then you're well set up for quality. In quality, you report 6 measures. One of those 6 measures has to be an outcome or a high priority area, and AOTA is going to help you figure out what all of that means. But you report 6 measures, and you're scored on how well you do on those 6 measures. Improvement activities, the other category, is completing 90 days of quality improvement using some specific activities. And this is the one I'm really excited about. So just so you have them and you can download the slides again, just as a reminder, here are the MIPS measures that apply to OT for the first year. The ones on the left are for claims, and the ones on the right are for registries or EHRs. So feel free to go through those in more detail. The link on the left-hand side under claims gives you a lot of information. But if you participated in PQRS, those measures will look very familiar. Improvement activities is a very, very large list of activities that CMS has published that your practice would get credit for literally doing something to make the care that you provide your clients even better. So you have to work on it for 90 days, but there's some really cool, exciting things for OT here. One is increasing the depression screening. So developing a plan around screening for depression, which is clearly in OT's scope of practice and may not be a formalized program in OT clinics right now. The second one I really love, engagement of patients, family, and caregivers in developing a plan of care. If that doesn't speak to OT, I don't know what does. But then you'll see another one for fall screening and assessment, and there's some others there that I think are really important. So by engaging in these programs and making our care better for our clients, CMS is actually going to reward OTs for doing that in Medicare Part B. So what ends up happening is you're scored in this formula, and don't stress out about the formula yet, but if you're one of the very worst performers, then you could get up to a negative 7% payment. And you have to do really, really bad to get the negative 7%. If you're one of the best performers, then you get a positive adjustment of up to 7%. Plus, Congress has thrown in an exceptional bonus where you could earn maybe up to 7.5% if you're just at the very, very, very top of performers in the country. So I know there's probably lots of questions about QPP bubbling up, and the good news is that Friday, November the 9th from 12 to 1, if you're willing to listen to me again, we're going to dive in super deep into QPP, and we're going to dig into the quality payment program for a full hour and go into the details. So you can register, the links there at the bottom. It's the same link as the other Member Appreciation Week webinars. But feel free to join us on Friday if you think QPP might apply to you. And now I will hand it back over to Sharmila to wrap us up.
Great, thank you, Jeremy. So I am going to move into very quickly, in the interest of time, providing us with an overview of AOTA's quality program. This is a program that began with the quality team, I want to say about 4 to 5 years ago, and really is trying to look at positioning occupational therapy to operate within this value-driven payment system and paradigm shift. So as you heard, we really need to maintain relevance for the profession, and the focus needs to be on delivering high-quality services that can impact not only each client, but also the health system level quality measures that Jeremy talked about that really go into the value-based purchasing program and the quality reporting program measures in giving us the ability to demonstrate the value and showcase the profession. So what is AOTA doing as part of our quality strategy? We have developed sort of a high-level set of goals and recommendations, and we're looking at OTs to work with us, who review, provide advice and insight, and recommend quality measures for each of the federal programs and settings that we spoke to you about tonight, and as well as other settings where occupational therapists work each day. We do that often through notice and comment directly to the Centers for Medicare and Medicaid Services. We also have many members sit on national technical expert panels in helping us do that. We work directly with quality measure developers across the country in helping to provide feedback on various measures that occupational therapy touches. And we are developing really kind of in the process as this being kind of our first kickoff presentation, but we hope to do a series of more webinars and presentations that help you understand this shift from the volume of services to the value of services and really understand what quality measurement might mean for you in the future. As Jeremy spoke about earlier, we have a number of clinical resources on the websites are listed on this slide for you to review and take a look at and bring to your practices. AOTA has, over the last year to 2 years, has developed an occupational profile template. I'm hoping that most of you who are listening tonight have seen that or accessed that in some way. It's available on the website and can be downloaded, and really uses the occupational therapy framework to take a deep dive in the evaluation process for clients. And we always welcome feedback on the usefulness of this tool for you across the age range and lifespan. So definitely want to hear from you on that. This is something that we know has been useful and gotten many, many downloads and hits. As I spoke about earlier, AOTA has appointed occupational therapy practitioners to a number of committees and expert work groups nationally over the last several years. These list over 20 of the groups that occupational therapists have been appointed to. The list spans several bodies that we work with and we are members of. We advocate with entities and bodies such as the National Quality Forum, the Consortium for Performance Improvement, and a variety of other organizations in addition to CMS and payers who are looking at quality measurement. We're also have a very great presence and influence on the national landscape with many of these quality bodies, and these are just a few. Happy to provide more information if you would like. And then AOTA has been working across our divisions to implement the Choosing Wisely campaign, in which there is the ability to list 5 things that practitioners really should question or think about no longer doing in the course of their practice. These are listed here, and there's also a link at the bottom of this slide which provides you with more resources and detail for how each of these were chosen, which was done through a very involved survey and vetting process with membership over the course of the last year, and want you to certainly take a look at these and provide feedback to us. And related to Choosing Wisely, another plug for Member Appreciation Week next week. There will be a session on November 6th from 12 to 1 with Glenn Gillen, who I believe is going to speak to you about this campaign and talk about each of those initiatives in great detail. So please do listen in. So in beginning to close the presentation, we leave you with these questions that we ask that you ask yourself as you think about your practice. We want you to think about how do you as an OT practitioner contribute to client and system outcomes, and really giving thought to long-term outcomes and cost containment and cost efficiency. Are you familiar with the Medicare quality programs, value-based purchasing, quality reporting, and now the quality payment program for Part B and outpatient therapy services? And really, how can you contribute every day to ensuring that the distinct value of occupational therapy is highlighted and really shines? Are you comfortable, if you work in post-acute care, are you comfortable with Section GG as a measure for self-care and mobility items? And do you consider yourself an expert? Can we become experts, and what do we need to do that, and what do you need from AOTA? And then have you thought about implementing a quality improvement project within your own setting, and know that AOTA has resources for that as well? Finally, we have slides under resources to access. We've created a set of bonus slides that really explores the Nursing Home Compare program. There are a series of compare programs across settings such as home health, long-term care, nursing facility, physician, et cetera, that look at these quality measures and where consumers can go up on a website and identify the facility or practitioner they wish to go to based on things like star ratings for these quality measures. So really, this information is being translated directly to consumers, and they're making their choices based on it. And so the importance is only elevating in this field of quality. And so that's just a slide that shows you a site, and then we have a slide that gives you a series of resources. So with that, I will open it up to questions and feedback. Thank you very much.
All right. Thank you so much, Sharmila and Jeremy. We have a couple of questions, and so I think Jeremy, I think you have some on the Section GG that perhaps you might be able to kind of put together there.
Absolutely. So there were a couple of questions on getting access to Section GG and the items for Section GG. Super thrilled to see that, because we do see that as a really critical element for OTs moving forward. So if you go to aota.org/care, and that link is provided in the slides if you download, then the reason it's /care, just if you're curious, is because the Section GG items are based on the CARE tool. So if you go to that, there's a Word version and a PDF version that you can download. And also, we're making these slides that we've used tonight available via PowerPoint in the resources section. So someone is asking about academia. Feel free to edit and use these slides as you talk to students about the importance of these. So feel free to use the tools and the slides. And someone asked about which items are being added in SNF for Section GG, and it is the full complement. So right now, or a few months ago, SNF only had, I believe, Sharmila, you might have to correct me, but I believe it was toilet hygiene, bed mobility. They had a smaller set of items. There was one more, but starting this year, they have the full complement. So again, if you go to aota.org/care, we have all of the items listed there for you.
Thanks, Jeremy. And then we had a question, and this is a pretty common question that we're getting, whether or not we anticipate any layoffs when the OT minutes and SNFs are no longer counting. And, you know, I can't really say for certain what's going to happen. I think it's really hard to be able to predict these days. We do know that we saw it with the last time that we had a massive payment change, and that's why we're really trying to come out with all this information on the front end. I would also tell people to please go to the August Member Appreciation Plus webinar. If you look at the Member Appreciation webinar library, you'll find it there, because we talk about how occupational therapy can position themselves to not be as subject to potentially those changes in position. And what it really comes down to is making sure that we're showing our value and demonstrating our value each and every day in our care with our patients, as we're talking to other health professionals and family members, and then making sure it's in our documentation as well. So I think that it's an important thing, and we would encourage you to definitely review that webinar from August, because I think it'll give you some strategies as well to position yourself for success. Sharmila, I know you have a couple of questions too. Do you have one on the list you want to take?
Sure. There were a couple of questions about how this will affect other payer types, such as Medicaid, private insurance. As we've often said, Medicaid is usually sort of the gold standard where there's some trickle down to other payers, but at this time we're not aware of any implications that are identical for Medicaid or private insurance in terms of Section GG. However, there are initiatives in private insurance to really look at things that we refer to as alternative payment models, to introducing the concept of quality measurement and cost reduction to really make more efficient delivery models of delivery systems, and then also reimbursement. So you'll see, if you go up on our website under the Medicare tab, we have a page on alternative payment models, and that provides some examples of those types of models. There was also a question here about whether or not these payment changes apply to physical therapy, or is it just occupational therapy? These payment changes that we talked about in Medicare tonight definitely apply to physical therapy the same way. They apply to occupational therapy as well as speech language pathology. So all of the therapy disciplines are being treated the same way. And in addition, really the entire healthcare system, where you're not alone here. These are changes that are affecting physicians to nurses to every practitioner within the system, and so want to be sure that's understood.
Yeah, absolutely. Great point, Sharmila. It's good to know that we're not alone in this space, and everybody is really trying to figure this out. Jeremy, do you have another question off of your list that you'd like to take?
Yes, so someone asked about a measure that more people may have heard about called Medicare spending per beneficiary, and how that may relate to QPP. That measure actually is also in some of the other settings. So for QPP specifically, that measure will not apply to OT for the first year if the final rule matches the proposed rule. So we don't think that it will be specific and used to rate OTs. It is used for a lot of physicians at this point. So take a sigh of relief and keep your fingers crossed both on that one, because it can be complicated.
There was also a question about whether or not the recording was going to be available to watch, and the answer is yes. So I would definitely encourage you to do that. And then also, Jeremy and Sharmila did highlight a couple of the additional sessions that will be happening next week during Member Appreciation Week. And again, those are free for AOTA members. You can earn a CE credit for participating, and so we encourage you to do that, because they'll be able to dive deeper into some of these different areas as well. Sharmila, do you have any other questions on your list?
Just quickly, there was a question about the MIPS program, asking if it is only currently for private practice occupational therapists. And yes, that is correct. At present, it is private practice occupational therapists. Occupational therapists who work in facilities or facility-based practice are not currently subject to the MIPS program due to the billing mechanism. There's a sort of complexity there. However, in this final rule, we did learn that CMS is looking at expanding the reach of MIPS to hospital-based physicians and perhaps in the future to skilled nursing facility practitioners. And so we're looking really closely at what that might mean for therapists, so stay tuned.
Great, thanks, Sharmila. I know we're approaching the end of our time together this evening, and we do have some questions that are here, and we'll take a look at those this evening. And if we didn't get to your question, we can definitely follow up with you. We appreciate the questions too, because it helps us understand a little bit more about different strategies and things that we can include in presentations that we'll be continuing to develop as we move forward. And definitely encourage people to plug into those member appreciation webinars next week as we celebrate all of you as members of AOTA, and we're so grateful to have all of you. So thank you to Jeremy and Sharmila for spending a part of your evening with me, and for Amanda, who is our person who helps make this system run for us and just makes everything come together. Appreciate all of you tonight and all of the members who joined us. And thank you so much. We'll look forward to talking to you again on a future webinar. Have a good evening, everyone.